What about patients with high blood pressure? Well, they seem to behave just like normotensive patients. In other words, everybody that goes to altitude will get a slight elevation in blood pressure with increasing altitude. But that elevation is probably around 15 millimeters of mercury systolic and 5 millimeters of mercury diastolic. There's nothing to suggest in the data that this is significant up to about 3,000 meters of altitude, and there's actually very little data beyond that, as you might expect. Hypertension does not appear to be associated with the development of AMS. There is a subset of people who develop an exaggerated response to altitude, but this is unpredictable, and they may be both hypertensive and normotensive patients. So generally, being hypertensive as long as you're well controlled is not a contraindication to going to high altitude environments. What about the patient with ischemic heart disease? Well, again, as you might imagine, there's no good data above 3,000 meters. If the patient has stable ischemic heart disease and is well controlled, their risk factors have been modified, and they're under the care of a doctor who understands the nature of where they're traveling to, there's probably no risk in going up to altitudes of approximately 3,000 meters, and it may well be safer to go beyond. It's just that there's no way of knowing. Angina theoretically might be precipitated earlier, and it may well be that somebody going to high altitude who's known to have stable angina might need to make some adjustments to their exercise and workload throughout their trek. There is also an increase in ectopic activity that you see when you go to high altitude, but that in fact occurs to patients both with and without underlying ischemic heart disease, and that seems to disappear once you've acclimatized. And there's no evidence that arrhythmias are more common at high altitude. So, cardiac altitude, the concept of cardiac altitude, how high can you go if you've got underlying ischemic heart disease? Well, as I said, nobody knows. There are many reports of people who've had stents and bypasses, for example, who've gone to extremely high altitude with no significant problems. There have been hyperbaric studies that have looked at patients with stents and bypasses to 4,500 meters. And again, these have also demonstrated what we said before about patients at 3,000 meters, that there are probably no significant adverse consequences if you've got stable coronary artery disease. Ultimately, the reality is if you want to go higher, nobody can really answer that question, and you need to have a serious discussion with your treating cardiologist to determine the risks and the benefits. Asthma. In fact, some people going to high altitude find that their asthma actually gets better, and that bronchial hyperresponsiveness actually decreases. And that's probably a function of the fact that the air is cleaner, there's less dust, there's less allergens, and therefore there are less attacks. On the flip side, some people get an increase in their frequency of asthma attack because they find that they're induced by the cold and the physical exercise coupled with the significant hyperventilation that's induced by high altitude. However, for most patients, there's no increased risk, and if you've got well-controlled asthma, there's no reason why you shouldn't be able to travel to high altitude, and indeed, asthmatics have made it to the summit of Everest. Again, I think the common sense aspect here is if you're planning a high altitude trek and you have asthma, that you should discuss the trip with your respiratory physician. Okay, venous thromboembolism. There is a definite increase in VTE if you go to high altitude, and there are multiple risk factors for this. There's dehydration, there's the cold, which results in vasoconstriction and therefore further stagnation of blood flow. Often you've had a long journey to get there, so you've got the risk factor of prolonged immobility to add into the mix. You're often living in cramped conditions with decreased activity on the mountain itself. Whilst trekking is a physical activity, you are a lot of periods of inactivity, particularly when you're trying to get up and conquer a particularly high mountain. And there's an increased hematocrit as a consequence of the polycythemia that occurs, as we talked about previously, in terms of one of the mechanisms by which you acclimatize to go to high altitude. The other thing that happens is platelets become stickier, although there's no known effect at the moment on the actual coagulation cascade itself. But the result of all of these factors is that the incidence of thromboembolism is substantially higher. And in fact, it's thought that the risk is probably 30 times higher at altitudes over 4,000 meters than it is at sea level. And remember that by VTE, this isn't just a simple DVT, not that a DVT should be considered simple, but it also includes pulmonary embolism, thrombophlebitis, and the much more significant and potentially fatal consequences of things such as cerebral venous thrombosis and stroke. Epilepsy. There's no evidence of increased fit frequency going to altitude. Clearly, if you're going to go on a trekking expedition anywhere, altitude or otherwise, you need to be well controlled and understand your medications, and you need to relate the risk of a potential seizure to the activity that you're undertaking. Again, common sense should prevail here, and it's important to have a discussion with your neurologist before undertaking any such activity. So, if we talk about people who've got pre-existing medical problems and want to go to altitude, who should go? Well, generally, this group here probably have no increased risk. The very young and the very old, it really comes down more to their level of aerobic fitness. There doesn't appear to be an increased risk of altitude illness if you're fit or unfit. That simply affects your capacity to undertake the physical work required. Similarly, being obese does not appear to have a significant effect, although there is a hint that perhaps there might be a potentially slight increase in the risk of AMS. That's not really definitively proven. Stable, well-controlled diabetics, people with stable coronary artery disease, people who've got well-controlled hypertension, stable epileptics, stable asthmatics, and those with relatively mild and well-controlled chronic airflow limitation, they probably can all travel to altitude, but in terms of how high they go, that really needs to be something that they discuss with their own doctor and put it in the context of their illness, the degree of control that they have for their illness, and the nature of the activities that they want to undertake. In terms of increased risk, patients with moderate chronic airflow limitation, patients who have coronary artery disease, ischemic heart disease who are actually symptomatic, people with established heart failure, people who've got prior history of cerebral vascular disease, and those who have any medical condition that's poorly controlled, particularly epilepsy and diabetes. And obviously, if you have severe disease of any sort, you really shouldn't go to altitude. So that would include severe chronic airflow limitation, severe coronary artery disease, severe heart failure. For obvious reasons, if you have established pulmonary hypertension, then you shouldn't go because of the substantially increased risk of developing high altitude pulmonary edema. And patients with severe mental health disorders should not travel to altitude because, of course, functioning at altitude requires a significant control of your mental faculties, and if you've got poorly controlled mental health disorder such as active psychosis, you're a threat not only to yourself but to others in any kind of expedition environment, altitude or otherwise. Ultimately, when weighing up whether somebody with a pre-existing medical problem can go to altitude, a lot of factors have to be taken into consideration. It depends on the altitude that you're going to. It depends on the activity that you are specifically going to undertake. It depends to a great extent on the medical support that is available on the trek, and also on how quickly you can be evacuated from the trek. Not only how quickly, but how easily you can be evacuated from the trek if a problem were to occur. It depends on a lot of other intrinsic patient factors, and in many respects, common sense is probably more important than science, because in reality, for most medical conditions, we have virtually no science that tells us exactly how they're going to behave or react once they get over 3,000 to 4,000 meters above sea level. And here we are, descending from the lava tower on the Schiller route down to the Barranco Wall, which on the Schiller approach to Kili is actually a particularly exciting and quite fun day.